Hello, everybody. Sorry, I was a few seconds late there. I was distracted by a LinkedIn article I was just reading. Anyway, thank you for giving up some time over your lunch or just after lunch. And welcome to a session I'm going to be presenting, talking about pharmacogenomics or PGX, and in particular using the example of Clopidogrel and the impact that pharmacogenomic testing can have in this specific drug. I'm going to share my screen, which has a PowerPoint presentation, which I'm going to go through so that you can see those slides and hopefully enjoy what I'm going to be saying about pharmacogenomics. I'm going to try and get something out of the way of the middle of my screen first before we start. Okay, so how pharmacogenomics or PGX can and is starting to transform patient care, and with specific reference to Clopidogrel, as I said. Okay, just a little bit about me. First of all, I'm Dr. Mark Hudson-Peacock. I'm founder, chairman, and CEO of Mantara Health Limited, a UK company that has launched the first CE and UKCA marked pharmacogenomic panel test, fully registered with the MHRA in the UK. Mantara Health Limited nor myself are receiving any remuneration for today's presentation. What is my background? So I studied in Cardiff. I qualified as a doctor there in 1987. It's a long time ago. I've been a consultant dermatologist for nearly 30 years, and I'm the Chief Medical Officer for the Dermatology Partnership, which is the largest privately manned dermatology clinic across the UK, with 8 clinics and growing, now owned by Bupa. I'm the co-founder, chairman and medical director of the Xroid group of companies. And as you heard just now, I'm the founder, chairman and CEO of Mantara Health Limited. Therapeutics has always been a passion for me. And when I was an NHS consultant, and I left the NHS just over 11 years ago now, I sat on the Drugs and Therapeutics Committee for all of that period of time. Such was my interest in learning more about medications, the new ones, understanding and trying to create better and safer prescription pathways for patients. Back in those days, pharmacogenomics was a research tool and wasn't used in any pragmatic way in terms of healthcare delivery. Fast forward a whole bunch of years, and now we're in a very different position and on the verge of really transforming prescription medicine. Sustainability is also a passion of mine, and pharmacogenomics really feeds very nicely into that agenda. It reduces drug waste as a tip of that iceberg. I will say this again in a minute, but when you consider that 90% of the medications that are prescribed only work as intended in just 30 to 50% of the patients they're given to, which is staggering. One anticipates as a doctor when you're training that when you prescribe something, it's going to work. Some people, it doesn't seem to, and some people get side effects, so you fiddle around with it. But when you see the stark reality of that statement, actually, half of medications really don't work in us. And we have a tool now that can decide which ones work in which patients. Do we need to adjust the dose? And I'm going to go and explain a bit more about that as this talk progresses. So I'm going to say it again now. 90% of drugs are effective in only 30 to 50% of patients. In other words, most drugs don't work for most people. If you look at patients who are 70 years and older, 89%, that's virtually 9 out of every 10 patients, are taking at least one drug with a known genetic interaction. Commonly prescribed medications are ineffective or less effective for 46% of patients with depression, arthritis, diabetes and asthma. And in the recently updated Progress study, 28% of patients prescribed proton pump inhibitors, antidepressants, statins and Clopidogrel end up changing their prescription. That's more than a quarter of patients are changing their prescription, just looking at 4 genes, looking at these 4 different drug groups. So introducing pharmacogenomics or PGX. So pharmaco, it means drug related, and genomics, gene related. So putting that together, it's a bit of a tongue twister. So we call it PGX. It's a lot easier. But Imagine a healthcare system where medical decisions are not based on a one-size-fits-all standard, but where the needs of each and every patient can be considered based on their unique genetics, their lifestyle, their environment, and even socio-economic factors. As a doctor, I've been there, watching patients struggle because the first line of treatment I've tried did not work as expected. Pharmacogenomics changes this narrative. It allows us to predict how well a medication might work in a patient based on their unique genetic makeup, so-called personalized medicine. How many patients experience unwanted side effects from a medication, some of which can be life-threatening? Well, a study done in Liverpool was reported and showed that up to 16.7% of acute admissions through the A&E department were down to secondary to severe adverse drug reactions, also called ADRs. PGX takes the guesswork out of prescribing. It allows us to prescribe the right drug at the right dose first time. The holy grail, you might say, for prescribing is here, and it is going to change prescription medicine forever, starting now. And you may not know how to start now as a medical provider and as a patient, but it's about asking questions. It's about pushing your medical doctors and saying, I've heard about this. Do you think it could help me? And the answer is it can potentially help everybody. So what can pharmacogenomics bring to the table? Well, significant cost savings can be achieved. Drug waste can be significantly reduced. Well, if half of the drugs we're prescribing don't actually work in patients, and we can predict that by doing their genetic tests, why give it to them? That's 50% of drugs that are being wasted unnecessarily. Of course, along with that, doctors' time is going to be wasted. So we can free up a lot of doctors' time to be able to see other patients that are in need, maybe able to get the NHS waiting list down. Even the waiting list now on private lists can be reduced as well. And most importantly, patients like you will be healthier. You'll have an improved quality of life, with your disease or diseases being managed using the right medications for you at the right time and at the right dose. This is the promise that pharmacogenomics provides as part of precision medicine. Now, you might ask, and there are some questions I'll deal with later, well, if it's so good, why aren't we doing it? Well, I think there are three different types of active prescribers out there. There's the type 1, which I've called those pharmacists and doctors and nurses that can prescribe, that know about pharmacogenomics. They appreciate it can potentially change outcomes for patients, and they've read some studies and have a basic understanding of it and find it interesting. However, in real life, they are too busy. It's too hard or too new. It's not their job to implement this. Someone else can do it. They chose the status quo over change. And that type of attitude was with us before the pandemic, when no one to any great extent was doing online consultations. It was too hard, it was too difficult, they were too busy, it was too new, it wasn't their job. Someone else can do it. The pandemic happened, and within 2 weeks, everyone was doing it because they had to. So making people change is one way to achieve changing how pharmacogenomics is managed out there. There's also then the type 2 prescriber, those that have never heard of pharmacogenomics. Not their fault, it was not taught at university, and it's not crossed their radar of knowledge gathering. Probably as they're too busy trying to fight to keep their day jobs managed, keep their heads above water, managing the patients that are coming in one after another, because of the relentless demand on them. No one has handed them the key to the PGX door, as I have termed it. And then there's the type 3, those that think about and use this tool in their patients. This group are the movers and the shakers, the early adopters, and they appreciate that PGX is a game changer for helping guide medication choices for each patient they see. They know that the patient's genetic variants can predict if a drug will work or not, and if it might cause harm. They know that if someone is a poor metabolizer of CYP2D6, codeine, a common painkiller, won't work. If they're a rapid metabolizer of CYP2D6, codeine, in an extreme example, could kill them. So there's a good reason to know what your metabolizer state is with regards to CYP2D6 if you're going to be taking such a medication. They know also that variants of the CYP2C19 gene can mean that Clopidogrel will not protect patients from having another stroke. And these sort of questions and answers are not interesting trivia, but life-saving knowledge. And it is beholden on us to become type 3 prescribers going forward. Unfortunately, at the moment, there are very few of us that are in that category. But when you know about pharmacogenomics and can see the impact it's having on patients' daily lives, I think it's now our ethical duty to use this tool in all patients. And that doesn't mean to say just because it's not available on the NHS at the moment that we shouldn't talk about it and advise patients of it, because it is available privately. Ultimately, it will become available on the NHS, and then it's going to be available to everyone, irrespective of their ability to afford to get the test done. However, it's not massively expensive. So, with everything that PGX has to offer, why isn't it being used already? Well, prescribers, and that includes pharmacists, doctors, and nurse prescribers, all need to be aware of and use this amazing tool for the benefit of their patients. So why aren't they using pharmacogenomics now if all this evidence is there, which it is, and increasing in volume every single day as studies are carried out across the world, looking at the genetics and the pharma aspects and putting it all together and showing just what a difference it's making. Is it a lack of education and awareness? Absolutely. Most doctors aren't aware of pharmacogenomics. Most pharmacists aren't aware of pharmacogenomics. Most patients aren't aware of pharmacogenomics. So there is an awareness situation. So education is critical. The good thing is it's now included in pharmacy curricula. So pharmacists are being taught about pharmacogenomics before they qualify. It's not on medical curricula, but it should be. And I'm in talks with the local dean at the Kenton Medway Medical School with a view to trying to make sure that it is part of medical curricula, at least locally, but it should be done nationally as well. Is it because it is too expensive? Well, no, it's not. There was nice guidance published last year relating specifically to Clopidogrel, suggesting that as long as a test costs less than £1,920, it will save money for the NHS. The test costs significantly less than that, and therefore it is going to save a huge amount of money for the NHS. Can our hard-pressed NHS healthcare system implement testing currently? No, it can't. There are no labs in the UK that can implement broad panel-based lab testing to do this. I know I've been looking for a lab for 4 years, and we have now found one, and hopefully at the beginning of July we will be going live with a UK lab that will for the first time be able to use panel testing to allow us to get tests back much more quickly than we're able to at the moment. Is it too hard to do with all the other priorities? Absolutely. The NHS is struggling. The private sector is struggling in certain areas with the demand on the services, and they're looking at quick wins and business plans that come in. They can't do them unless they're going to save money in year. No one has thought about pharmacogenomics because it really can save a lot of money within year, and therefore should be implemented across the board in many areas, even if starting in a few to prove it and then to bring it out more widely. Is it because medical politics and academics inadvertently slowing progress? Absolutely. Medical politics is the bane of a lot of progression within the NHS, believe it or not. Yes, there's loads of good stuff going on, and there are loads of amazing drugs that have been prescribed, but the politics just slow the whole thing down, and that's frustrating. Medical devices are not managed in the same way that drugs are. So if NICE, the National Institute for Health and Care Excellence, approves a drug for the NHS and guidance is issued, within 3 months, the trusts need to come up with a plan to take it on. However, a medical device, no such game rules apply. It's an optional extra, and that needs to change. I think that is unacceptable. There are lots of very good medical devices out there that can make a massive difference to the patients within the NHS. So, what does it mean for us here in the UK in the NHS and private settings then? Well, genetics in the broadest sense has, up until now, been seen as a specialist area only practiced by clinical geneticists. But pharmacogenomics is different. As I've said, it's now our ethical duty to offer pharmacogenomic testing to all patients, bring it to their awareness. They can make their own decision whether they want to do it for themselves or a loved one. It will be used by all prescribers in both community and hospital settings in due course, and it is already part of the new pharmacy curriculum, as I was saying, and now we need to get it more widely educated along with medical students, nursing students, so that everyone is aware of this vital prescribing tool. Why? Well, because of the impact of pharmacogenomics can have on many of the commonest medications we use today. The Mantara test covers 77 of the commonest medications used in the UK, and this is evidence-based and validated by the largest pharmacogenomic test that has been done and published. And this was in The Lancet in 2023, looking at almost 7,000 patients across Europe, including 1,000 or so in the UK. We know that it makes a massive difference in terms of reducing adverse drug reactions or side effects, indeed reducing them by 30%. A recent study has suggested that if patients have a pharmacogenomic panel test, it will have an impact on about 80% of their patients over a lifetime. So most patients, it will have an impact on them. It will reduce adverse drug reports and reactions. It will improve the effectiveness of treatment. It will improve the safety of treatment, and it will encourage patients to stick to the prescription rather than I'm getting some side effects, I want to stop it, and stopping it. And that happens a significant amount of the time. And when I visited patients at home, the drug cabinets are a scary place. There are so many drugs in there that haven't been used, that are out of date, that really should not be in there. So there is a huge amount of waste in probably every household in the country if you went to their little drug cabinets, their little hideaways. There is a thing called a yellow card system, so that when patients have a significant allergic reaction, it's reported on a yellow card. And there was a recent study looking at these, and 1.3 million yellow card reports were looked at specifically where pharmacogenomic principles, if applied, how many could they have stopped happening? Well, 9% of those would not have happened if patients had had PGX panel testing before having the prescription given to them. That's a huge number of adverse reactions. And as you know, there are many more reactions than ever reported. The number of patients that are going to be impacted is massive. There's also the NHS aim to become carbon net zero by 2040. And this carbon footprint is significantly impacted by medications, so we can reduce that carbon net zero aim. And with 20% of pharmaceutics impact in the NHS's contribution, we can make it much more efficient and reduce that, and therefore contribute to the carbon net zero ambition. As patients like yourselves will find out about pharmacogenomics, you'll increasingly demand access, which will be fantastic. Now, you're going to have to hold on. I realise I'm plugged in and I'm about to run out of juice, so 2 seconds. Right, I'm back. I've got juice. We're all good. Apologies about that. That's an amateur mistake. Right, so what does it mean? So genetics in the broadest sense, as I said, has been practiced by clinical geneticists, but not now. So further on down that list that I was getting to, the cost savings that can potentially be made are potentially eye-watering. Now, that study I mentioned earlier on, where 16.7% of patients going to A&E has been looked at, and that's probably costing the NHS in excess of £2.2 billion a year. And of that number, probably 30 to 40% could have been prevented by doing panel testing or using pharmacogenomic principles. That's a lot of millions that can be saved. Ethnically diverse populations can benefit from implementation of pharmacogenomics, and that includes Clopidogrel, which I'll come on to in a minute, because that's quite impactful. And then within the information that we use in the British National Formulary, which is the Bible of medications, the so-called SPCs, which are the summary of product characteristics related to medications actually state that if you've got access to pharmacogenomic testing, do it. And that's certainly listed for codeine, which is a common painkiller, because if depending on your CYP2D6 variant, it may work for you, it may not work for you, or may, significantly harm you, possibly even kill you. So it's in our Bible. We should be using it. Now consider these facts. 8.7 million people in the UK were prescribed antidepressants in the year to March 2024. 46% of antidepressants do not work as intended in patients, which is a huge drain on resources. Wasted medications, ineffective treatment, and added burden of hospital and clinic visits, let alone the patient effects. Another fact, 1 in 4 people over the age of 25 will suffer a stroke in their lifetime. That's a large number of people. There are currently estimated 1.3 million stroke survivors in the UK, costing the NHS £26 billion a year. And this is estimated to increase to £75 billion a year by the year 2035, which is not that far away. It's a massive cost burden. So where does this all come from? Where do these variants come from? Well, we know we're all different. We look different. We behave differently. We have different skin colours, ethnicities, we're different. But where does this all start? Well, back in the day, plants defended themselves against being eaten, mechanically and chemically. The DNA variants developed in organisms of the consumers of those plants, something called xenobiotica. And this ability to vary the genes allowed certain animals to survive, to generate offspring, and to inherit DNA variants that gave them advantages going forward. So using that Darwinian theory of survival of the fittest, that's true, but it was also survival of those with the genetic variants that allowed them to eat and be sustained. Looking at a schematic of DNA, specifically around drug metabolism, depending on which particular letters you have, and there are 4 different bases that make up DNA, which are C, G, A, and T. I won't bother to tell you the names because it's not that interesting. However, we all have this code that makes up our genes. Now, with drug metabolism, if you've got a particular variant, a drug, as on the schematic on the right side, in a single dose, can work as it's supposed to. But for some patients, your variant might mean that you need much more than the normal dose to get the same impact. For other patients, you may need to have a lower dose to have the same impact. And for yet more, your variants may be lethal, it may be toxic, patients will get side effects, worst case scenario, it could kill you. Rare, but it happens. So what does that mean? So if we look at what we know, and we know that about a third of drugs will work as intended in patients, and 2/3 will have undesirable effects, and those undesirable effects may be a stronger effect, which could be toxic or lethal, given adverse drug reactions or ADRs, and the other third have a reduced effect or non-response. In other words, it's not going to do anything, such as in those with Clopidogrel who have a particular variant. And so what can we do? Well, if we know what the patient's genetics are, if they have a potential drug response that's going to be too strong or toxic, we can reduce the dose, or the decision may be for an alternative, better suited medication for that patient. And if a drug response is potentially going to be too weak, or they're a non-responder, we can increase the dose depending on that variant, or the decision may be for an alternative, better suited medication. So I'm now going to look at Clopidogrel as an example, because it's the first mainstream drug that's become the subject of NICE, the National Institute for Health and Care Excellence guidance. So there are 100,000 strokes per year in the UK. Clopidogrel itself is an inactive prodrug. That means that it has to be metabolized by an enzyme from the CYP2C19 gene to activate it for it to have a beneficial effect. And what does it do? Well, it reduces the stickiness of platelets. Platelets are a little tiny bit of material that floats around in the blood along with our white cells, our red cells, and everything else. If you cut yourself, the platelets sort of block the holes, stick together and clot and allow you to heal. However, we also know that in patients with disease, they can have heart disease, they can have brain disease where their arteries are slightly furred up. Sometimes the platelets can stick together and block an artery, which can give you a heart attack if it's in your heart, and it can give you a TIA if it's transient, or you can get a full stroke. And that can be devastating for all patients in the short term and certainly in the long term. And of course, anyone who's had any of these doesn't want to have another heart attack or a stroke. They want to reduce that risk, and Clopidogrel is the go-to medication because it's a very good drug when it works as intended by making your platelets less sticky. However, we know in the UK that it does not work as intended in 32% of the population. That's about 1 in every 3 people it doesn't work. And you wouldn't know that unless you had a test, or God forbid, you had a further stroke or TIA, making you realise that perhaps it hasn't been the right drug for you. And looking at the different ethnic groups, British South Asians, this drug doesn't work in 57% of them. That's more than half. And this is a group of people that, for reasons of their ethnicity, are at higher risk of having heart attacks and strokes. So it's really critical that patients know what their genetic status is so that the right choice can be made should they have a heart attack or a stroke, and if this drug is going to be used. You want to be in the 68% of patients in whom it works. You don't want to be in the 32% in whom it doesn't work, because we know from studies that it doesn't work and you don't get the protection and you are at high risk of having problems. So putting a pretty picture on it, so what actually happens? So you take the drug, it's a prodrug, it goes through your mouth, down into your gut, and in the intestines, it can be absorbed or it can be inactivated. Now, we know from studies that about 85% of the drug is inactivated in the gut and goes straight out the other end, but 15% of it is absorbed, it goes to the liver, and in the liver, there are enzymes that metabolize the drug to its active form. And this drug then this active metabolite then binds to a specific receptor on a platelet called the P2RY12 receptor. And that in turn inactivates a fibrinogen receptor. Now, these fibrinogen receptors are, if you like, the sticky glue that binds platelets together in situations of a cut or if you've had a stroke. And if you want to make those platelets less likely to stick together, you need to affect this degree of stickiness, this glue, if you like, and that is what Clopidogrel can do. So in patients in whom it is activated, it does a fantastic job, and we know it reduces the risk of strokes from studies that have been done. So the NICE guidance, I said, this was published in July 2024, and it states that people who have had an ischemic stroke or transient ischemic attack or TIA should have a genetic test to find out whether they can be treated with a drug which reduces the risk of further stroke. Indeed, Mark Chapman, who is the NICE Interim Director of Medical Technology and Digital Evaluation, stated that treatment with Clopidogrel is effective in preventing further strokes for the majority of people who don't have the gene variant. But until now, doctors have not known who cannot be treated with Clopidogrel until after they've had a second stroke or TIA, and that could be too late. Powerful stuff. But has anything happened since then? Well, there are 4 centres that are exploring this, working out the pragmatics of implementing such a service. But that means that the rest of the country are kicking the can down the road, and patients are not being able to access this potentially life-saving test in terms of what medication they will be prescribed. So to put it in a different way, the prodrug is taken, it's inactive, it goes to the liver, it's activated, it has its clinical effect. Happy days, that's the 68%. The 32% in whom this does not happen, the drug goes in, it's an inactive precursor, it's not activated in the liver, it goes out of the body, it does nothing. It has what we call loss of function, or LOF. And this can be as simple as one base being different. So the normal base at position 227 is a guanine, and it is changed to an adenine. And that one subtle change in a gene can make all the difference between does the drug work or doesn't it work. So simple, but if you don't know it, you don't know whether the drug's right for you. And here's a graph just showing the impact that having Clopidogrel active effect and inactive effect can have. So if you look at the red and the green lines, which are the top and the bottom ones, the red line is those that are taking clopidogrel in whom it doesn't work. And the risk of death, acute MI, or further stroke is significantly higher compared to if you have the clopidogrel and it does work for you. There's a big difference between it. Indeed, there's a massive difference. Okay, the drug is not going to protect everyone 100%, but it's better to be on it than not on it. And if it doesn't work for you, it's better not to be on it and have an alternative which will give you that protection. And that's the idea. So there are different types of PGX testing. The Mantara test is a panel test. And a panel test tests for multiple genes for multiple different drugs. As I said, the Mantara test looks at 77 of the commonest drugs used in the UK, which includes clopidogrel, it includes warfarin and other coumarins, which are blood thinners. It includes a lot of antidepressants. It includes proton pump inhibitors, statins, etc. And you can see that information on our website if you want to see the list of drugs that we do cover. And this has all been validated with the largest study in the world. The alternative way of doing it is point-of-care testing. This tests for different variants of a single gene for a single drug, such as in the case of clopidogrel. So GeneDrive are the company that have got a UK CA mark. And what I was reading just before this talk started was they've just announced they've got a CE mark for Europe as well, which is fantastic news for patients across Europe as well as in the UK. So their point-of-care test is a quick test. It can be done at the bedside in an acute setting, such as the NHS. So if you come in with a heart attack or stroke and people are considering clopidogrel as a treatment for you, you can do a test. Within a couple of hours, you'll know the answer, and then you can adjust the drug if you need to, or use as confident as you can when you know the patient works with that drug or the drug works with that patient. If it's going to be done in the private setting, it'll take a little bit longer because it's got to get from the lab to the patient, patient to the lab to test, and then the result to come back. But that's something that we're going to be doing very soon, working with GeneDrive to promote this for private patients, which are basically every patient that doesn't fulfill the NHS criteria of presenting with a stroke or TIA, for which the test can be used once it's implemented. At the moment, it's not there yet, apart from in a test format. So how does the Mantara PGX panel test work? Well, it's a simple and effective process. It's a saliva-based test. So if you order a test online, the box is sent to you with a tube for you to spit in. You have to register the test online and send it back to us. We then send it to the lab. We extract the 12 genes specifically related to drug metabolism, not anything else, just the ones that we're interested in. And then we look at the worldwide research that's been done on genetics and match your particular profile with all of that to give a personalized report that tells you, of those 77 drugs, which ones can you have and prescribe as normal, which ones you should completely avoid because they're potentially not going to work or be dangerous, and which ones you might have to adjust the dose of if you've got a particular variant. So it can be quite useful for if you're on medications now and you want to know whether they're the right ones for you, or for the future if you're not taking medication now, but at some point you will need to, where you've got a 1 in 4 chance of having a stroke. So at some point you might need clopidogrel or another blood thinner, and so that can be checked. So that is certainly something. It takes longer to get the results because it takes longer to process the genetic material, to get the answers, to sense check it, and then to get the report. It can take up to 2 weeks if you've got things very slickly organized. At the moment, it's taken 4 to 6 weeks because, as I said, there isn't a lab in the UK that can do the testing, and we send it to Germany. So there's always logistical challenges to get it there for them to do the testing for us. However, that's going to change at the beginning of July. We have been reliably informed as we will have, at long last, a UK lab that will be able to process the test for us, which will give us a turnaround time of 1 to 2 weeks, which is something we are absolutely hoping to get in place as soon as possible. So Mantara is the first UK CA marked PGX provider in the UK with a CE mark, fully registered with the MHRA. We're using the exact same protocols from the Lancet's UPGX Prepare study published in 2023. We are a medical device, and it's a Class 1 medical device under the UK and EU regulations. International compliance is met with global standards for data security and medical device regulation. The GeneDrive PGX point-of-care test, an even simpler and effective process. The process here is an easy cheek swab. You'll remember those when we had COVID times, we were doing cheek swabs. That gets a bit of material from the inside of your mouth, and from that we can look at the genetic variants of the CYP2C19 gene. We then know what your variants are, and we can tell you very quickly, certainly within a week, whether the drug suits you or doesn't suit you. So for private patients who want to know the answer to that question, because the NHS is not going to cover it, that is something that we can facilitate very soon. Not yet, probably from the beginning of July, at the same time as we offer our UK lab service as well for the panel test, but it should make a massive difference. Again, the GeneDrive is a UKCE marked PGX point of care provider in the UK, working with the NHS, and it has now just successfully gained its CE mark for its potential implementation across Europe, which is a fantastic outcome. Again, it's a Class 1 medical device under the regulations, and it too meets global standards for data security and medical device regulation. And Mantara is working with GeneDrive, as I said, to make this available to private patients in the UK starting very soon. So in summary and conclusion, PGX will soon be the standard of care and will lead to safer prescribing and improved health outcomes. The near future is likely to see a combination of point of care and panel testing. In the end, it makes sense that panel testing will be the way forward, because we will all be born, we'll probably have a test at that point, which will be a panel test. This will become part of our electronic patient record, and it will be relevant for the rest of our lives. At the moment, however, that doesn't happen, and it's not going to happen in the next 10 or 20 years, I don't expect, but it will in the end. So there is a definite need for point of care testing when patients don't know their results. And there is panel testing available for people that want to know their results, so they're forewarned and therefore forearmed for when the time comes. Hopefully it doesn't, but it's there if you need it. The evidence is mounting as to both the cost effectiveness of and the cost savings related to pharmacogenomics, and it will likely save billions for the healthcare and wider economies. I know from work that GeneDrive have done that their test, if it's implemented across the NHS in England alone, can save 3,000 second stroke admissions, saving approximately £160 million a year, releasing 62,000 bed days, 250 or 230, 250,000 days of professional care. These numbers are big, so the cost savings are going to be huge. And if you look at panel testing, which covers a lot of drugs, the savings are going to be even greater. And then looking at the carbon footprint that we're having on the world, and we're all recycling, we're all being careful. The NHS, as I said, is aiming for carbon net zero by 2040, and prescribing better, more efficiently, more safely is going to be a key part of achieving that particular accolade. The challenges now are around education, awareness, and implementation, and a need to focus on ensuring that pharmacogenomics remains equitable both regarding future research and implementation. And I think implementation is the biggest challenge, because we don't have the ability at the moment within the labs in the UK to fulfill the demand that is going to grow. So this needs to be factored in. But in the meantime, there is going to be a lab working with us to provide it for private patients. And in time, this is going to stretch across the NHS as eventually PGX will become a standard of care that we all have, and rightly so. And that day can't come any sooner. So I think it is now beholden on us as what I will call the type 3 prescribers, the movers and the shakers that really want to make a difference and drive this process of investigation for patients into our country, and to get patients better cared for, get the right drug at the right dose first time, and stop faffing around trying to find the right medication by trying this and trying that, and sometimes, and not infrequently, failing because 90% of drugs only work in 30 to 50% of patients. I think this tool is really very, very important. It's not a magic bullet, but it is a very important bit of information that prescribers need when prescribing for their patients, and that's myself included. I think it has made a massive difference to my practice already, and it's going to change the practices of everybody in time. So on that note, I am going to stop. I'm going to apologise for having to rush out and get my lead to plug myself in the middle of that, but we got there. And if there are any questions anyone wants to ask, please feel free to put them in the chat, and I will do my best to answer them for you. So I'm going to stop sharing my screen now, and I will look for any questions. Okay, can't see any questions yet, so you can put it in either in the open Q&A or in the chat. So please feel free to ask a question. I don't mind. Hopefully I can answer them for you. But if no one has any questions, I hope I haven't spoiled your lunch break too much. I hope you've gained something interesting out of this, maybe inspired to go and challenge your doctor to find out more about it if they don't know, move them from a type 1 or a type 2 into a type 3 mover and shaker, get them to engage, help them understand the importance of prescriptions. And then at the moment, because the NHS doesn't cover it, looking at the private sector, and obviously we're very happy to have questions and people who ask us more about Clopidogrel if that's of interest, but also any of the other drugs on our list that can be tested for. And this includes antidepressants, it includes proton pump inhibitors like lansoprazole and omeprazole for heartburn. And just a little anecdote on that while I'm waiting for people to put any questions in the chat. One of our patients was taking a blood thinner called rivaroxaban because he'd had recurrent pulmonary emboli, which are clots on the lung, and he had a joint problem, went to his GP and they wanted to prescribe ibuprofen. Unfortunately, if you go onto ibuprofen when you're on a blood thinner, the risk of having a GI bleed is much higher. And therefore the GP quite reasonably said, I want to prescribe a proton pump inhibitor, lansoprazole, for you. Well, the patient got out their Mantara report and said, well, if I need this because I'm an ultra rapid metabolizer of the gene that metabolizes proton pump inhibitors, I need a 3 times the normal dose. The GP was impressed with the report, was led by that report, and was happy to prescribe a 3 times normal dose of lansoprazole. And the patient did not have a GI bleed while he was on the drug, and therefore there was a potential bleed that could have been potentially life-threatening on one hand, but also the cost of managing that in the NHS, estimated to be about £20,000, was averted. That's just one story of where it can make a difference. And he had his test 2 years before. So this was definitely a preemptive test rather than something that was done because he wanted to have a proton pump inhibitor. Right, Lloyd. Thank you. Re the point of care option, that seems very easy and quick and provide a massive cost saving to the NHS. When do you see the NHS taking this up? Oh my goodness, that's a good question. At the moment, there are 4 sites that are using the Gene Drive test, and they're implementing it within those 4 sites. Once the information relating to that has been assimilated and written up, and the evidence for it shown in real world use, I think that's the point when trusts will start to take it up more meaningfully. I would say that the evidence is there already. I mean, it really is. And it's just an excuse. And that's why, as much as I admire and love academics, and I have been one myself and still am, there is a real problem of academia stifling progress because of getting more studies done to prove it beyond reasonable doubt. And I think it's been proven beyond reasonable doubt already. And I think it's just an excuse to kick the can down the road. So that might be a controversial answer, but I think there's a lot of truth in it. And I think that's true for a lot of medical devices where the evidence is there, but there are no reasons why trusts have to take it on board, unlike drugs. I'm sure it's got something to do with powerful, very rich drug companies being able to influence changes, perhaps. Maybe that's me being a bit cynical in my old age. So I think I'm hoping later this year, but realistically, I would say probably next year. But the sooner the better, because every day missed, as I said, is another day a patient may have had another stroke, which may have ended their life, or it's certainly massively impaired their quality of life. So the sooner the better. But it's still only going to be applicable to those presenting with a stroke or a TIA. It doesn't cover all the patients who've already had one who are on the drug and they don't know whether it works for them or not. So I think that also covers John's question as well. So thank you for that question. Any other questions anyone wants to ask? And I'll do my best to answer. If not, I don't want to keep you any longer but if you have questions later, you're very welcome to reach out to us. Our website is mantara.co, and we're very happy to help with any questions that anyone might have. So thank you very much for giving up some time today to listen to me yakking on, and hopefully I've enlightened some of you. I've given you some confidence, and hopefully we can get something moving. And I think that will be a great thing to achieve. And it's something that all of us within the pharmacogenomic field are trying to drive, raise awareness, get people to understand it, both within the medical profession as well as patients. And gradually between us, we will hit the ground running and get this implemented at the earliest opportunity. It's going to save lives and save a huge amount of money and resource within the NHS and private settings. All good things. But particularly, it's the patients that I'm focused on, and I want everyone to have the opportunity of taking advantage of this amazing research that's been done over the last 30 or more years. And it's only now that it's culminated into a test that can be done that's really evidence-based, actionable, and at a price that is not out of this world for most people. Hopefully, and because you don't need to keep on repeating the test, the results that you get from these tests are relevant for the rest of your life. So it's not something you've got to do again and again and again. On that note, thank you, everybody, and I will leave you in peace to go and get lunch if you haven't had it, or to go for an afternoon walk in this rather pleasant weather we're having this afternoon. Thank you very much. Bye-bye.